Hello friends, this is Dr. Naveen Agrawal. I am an interventional cardiologist practicing at Valsad and Vapi district of Gujarat. My topic for today's discussion is regarding CT calcium scoring. What exactly is this test? What exactly are the candidates where CT calcium scoring should be done? What exactly are the indications for which it should be done? What exactly are the pluses and minuses for this? What exactly is the information which is given by the CT calcium scoring? This is what we'll be discussing because a lot of people on a day-to-day basis ask us about this in the comment section that they have been advised CT calcium scoring, whether they are candidates for it, whether they should do it, whether this is replacement for angio, whether this is an absolute alternative for an angiography, whether they will require the performance of an angiography after they undergo a CT calcium scoring, whether angioplasty can be decided on the basis of CT calcium scoring. All these questions we'll be trying to answer during the course of the next few minutes. I would request the people who are new to my channel to subscribe to my channel to give this channel more motivation and inspiration. If at all you are having any patient related queries or questions or any other topics on which you want us to make more videos, you can write to us about them in the comment section below. The people who do not want a very detailed and elaborate discussion about medical topics and just want only a gist and the summary, for these people I would request them to go to YouTube Shorts. For all these videos and about the salient features of these topics, I have made a lot of short YouTube short videos for 1 minute, and in this I give a lot of the summary about these factors. So you can subscribe to my channel and see these YouTube Shorts to gain a large amount of information, that too without wasting too much of time about the diseases which you don't have. So for these people I would recommend them to go to my channel having YouTube Shorts. Coming back to the topic, my topic is regarding CT calcium scoring. CT calcium scoring is basically a non-invasive screening tool sort of a thing in which we ask the patient to lie down on a CT scan machine, similar to what is done for a CT angiography or a regular CT scan. The patient lies down on the machine, contrast is not injected, only the scanning of the patient is done using the regular non-contrast CT scan technique, and the calcium which is deposited on the coronary vessels, that is calculated. The interpretation of this calcium is based on the fact that how much calcium is there on the coronary vessels, how many vessels are involved, what is the extent of calcification, what is the density of the calcification, and it is considered that this is a correlate of the disease and the chance of the patient having a heart attack in the future. But the problem with CT calcium scoring is that it in elderly patients, irrespective of the fact how many blockages the patient is having, the CT calcium scoring will be high, because with age calcification of the vessel is a degenerative process, and over a period of time all the vessels will start to get some amount of calcium deposition irrespective of the fact whether there is any blockage or not. So presence of calcification in a coronary does not absolutely without doubt clear the fact that the patient is having a significant blockage, and it does not also determine whether the patient will have a heart attack. A large amount of young patients who have heart attacks, they might be having a completely zero calcium scoring, and still there might be significant blockages, and still they might end up in a heart attack, because a large amount of patients will have a 20, 30, 40% blockages with no calcium. Calcium is only a degenerative process which deposits in the vessels over a period of time after several years of the patient having disease, and preferably in the elderly patient it gets deposited in the coronary vessel. Young patients without calcium need not be necessarily having completely clean coronaries, because a large amount of these patients will have 30-40% blockage, even 80-90% blockages might be there in these patients without having absolutely any coronary calcium deposition. So the calcium score, although it might predict that there is some disease in the vessels, but the extent and the percentage of the blockage and the likelihood of the heart attack getting in the patient having a heart attack in these cases may not always be correctly predicted by a CT calcium scoring. It will only tell you that there is some disease in the vessels which further needs a CT angiography or a regular angiography to confirm what is the percentage of the blockage, and the final decision on the treatment pattern absolutely has to be made only on the angiography reports and not on the CT calcium scoring. CT calcium scoring, if at all it is very low or it is almost zero in a young patient, then that will mean that there is not significant disease and the negative predictive value is reasonable. But again, as I said, that it does not guarantee you that there will be no heart attack, it does not guarantee you that there is no blockages, it does not guarantee that you do not require any medicines, because it is just a screening tool. It will only tell whether there is any calcium in the coronaries. The calcium may or may not correlate with the extent of any blockages. That is why CT calcium scoring does not find too much of an importance as of now. Majority of the centers, whenever we are doing a CT angiography, at that point of time simultaneously they do a CT calcium scoring. But isolated CT calcium scoring does not have too much of a meaning. If a patient comes to me with a calcium scoring of 400 also or 0 also, majority of the times I cannot give a complete guarantee to the patient ki what exactly is going to happen, whether you require medicines or not, whether you require any other further tests or not. Majority of the times you will again require a CT angio or a regular angio to confirm the findings. So at the end of the day, the knowledge which is given by the CT calcium scoring may not be absolutely critical in the management of the patient, and still a lot of questions remain unanswered after doing a CT calcium scoring. That is why CT calcium scoring as of now is just like a routine screening test, like we do ECG test, we do an echo test, we do a treadmill test, we do a CT calcium scoring, because it is non-invasive. You just do a CT scan and do not inject contrast into the patient. Only some radiation is passed to the patient, so that is a side effect. That is why we cannot ask the patient to do a CT calcium scoring every third month, because treadmill, even if you do every 6 months or every 8 months, it doesn't matter, because it's just a stress test. You ask the patient to walk on a treadmill and it does not harm the patient. But CT calcium scoring has some amount of radiation which is passed through the body of the patient. That is why multiple times CT calcium scoring also should not be done. And because the reliability of the report is not much, that is why routinely it is not recommended, because at the end of the day, when the patient comes to us, he wants as a guaranteed report. You tell me what disease I have, what medicines I want, what is my prognosis, how much is the risk of heart attack, what exactly should I do. If at all none of this information you give to the patient, you tell him, I don't know whether you need medicines, I don't know what is the risk of the heart attack, I don't know you have any blockages or not, then it doesn't make any sense for the patient, and patient usually feels that he is being made a fool of. That is why it is recommended that CT calcium scoring should only be used as a screening tool in young patients, where you just want to see whether there is any significant disease or not. But if at all CT calcium score does come positive, you will have to require a subsequent test to confirm the findings and plan the treatment strategy accordingly. Young patients who have had a mild treadmill positive, or a very low risk patients, or patients with mild ECG changes or echo changes, these patients you can send for a CT calcium scoring. It will give you some information as compared to what is available with the ECG echo treadmill. It will give you some additional information, but it will not give you a definitive answer based on which the strategy of the treatment can be decided. Now, how is the CT calcium scoring determined? Basically, a Gatson scoring is the system which is score system which is calculated. Density of the calcium which is there on the coronaries, that is calculated. If, for example, if the patient is having a Hounsfield unit density of CT between 130 to 199, he is given a score of 1. If density is between 200 to 299, we give a score of 2. If the score is between 300 to 399, we give a score of 3. If the score is more than 400 Hounsfield units, we give the score of 4. This is multiplied by the millimeter of the area which is involved in the given coronaries with the extent of the calcification. For example, if the patient is having a 7 or 8 millimeters area which is having a Hounsfield unit of 400, that means we have given a point scoring system of 4 to this. So you multiply 8 into 4 and you calculate the Hounsfield units, and the calcium score will become GT calcium scoring, or the Gatson scoring of this patient will be 32. 8 millimeters area involved multiplied by 4 is the score. So you get a score of 32. If a 20 millimeter area is involved and the scoring is 3, then 20 into 3 you get a scoring system of 60. Similarly, if the patient is having extensive calcification, maybe 100 millimeter area is involved of the coronaries which is having extensive calcification, and the score of each area is around 4. Hounsfield units is more than 400. Then the patient will have a Gatson scoring of 400. So based on this, we can calculate how much is the intensity of the calcification and what is the extent of calcification. Obviously, the more is the calcification, more is the extent of disease, the more likely is the patient to have a blockage. But what is the exact percentage of the blockage? That is very difficult to decide just on the basis of a CT calcium scoring. You further need to do an angiography to confirm, but that will give you a rough idea, and based on that you can at least decide whether the patient requires some medicines or not vaguely. There is no technique or no medicine which helps us to significantly reduce the calcification. This is the most common question which a lot of people ask us, that suppose my CT calcium scoring is 300 or 400 or whatever, and my angiography does not reveal any blockage, whether there is any technique which can reduce the calcification, and what harm will this calcification do. Obviously, the more is the calcification, the more is the intensity of the calcification, the more tough will be the angioplasty, the more likelihood that the patient will require a rotablation or intravascular lithotripsy or laser or something like that to break open the calcium. That will make the procedure much more tougher. There is no medicine which reduces the calcification because it's a degenerative process. Over a period of several years, the blockage will have slowly some amount of calcification. A lot of this depends on the genetic tendencies and other factors also. Dietary calcium does not affect it. The dietary calcium whichever you are taking in the diet, usually that does not have a significant amount of role in deciding the coronary calcification. So even if you stop taking all amount of calcium in the diet, still the coronary calcification will not be reversed, and it is not a completely reversible process. In this topic, we have discussed that CT calcium scoring is basically a screening tool which will help us to know whether the patient requires an angiography or not. If at all the CT score is completely 0 or very low, the requirement of an angiography is very low in these patients, but it will not give us a complete guarantee, and the management strategy and the medicine strategy and the long-term treatment strategy and prognostication, everything cannot be done very accurately with the help of a CT calcium scoring. That is why this test is not used very often, because the amount of information which it gives to the patient is not very much, and at the end of the day, the patient is receiving some amount of radiation which is detrimental for the patient in the long run, because one CT scan can give more than 100 X-ray. That amount of radiation might be passed through the body of the patient. So multiple times we cannot do it as a screening test every 6 months to 1 year just to see for the calcification. That is why it is as of now, majority of the cases it is almost outdated, and most of the cardiologists do not recommend CT calcium scoring for a patient. I do not remember a single patient where I have purposely advised to my patient to get a CT calcium scoring done, because it doesn't make too much sense. If at all the patient is having a positive treadmill, we straight away go for an angio, and if at all there is a normal treadmill, no risk factor, nothing and all, then we usually continue with medicine. CT calcium scoring usually will not make too much of a extra sense to the patient, given the cost and the risk and the radiation which is given to the patient. If at all you have any comments or queries regarding to this topic, or if at all you have any other topics on which you feel we should make videos, or any patient related queries, you can write to us about them in the comment section, and you can feel free to discuss about your problems. If at all you want all the cardiology related information or the cardiac problems related information in a very brief or short session, you can refer to my channel, where we have a lot of YouTube shorts on which you will get all this information in very short, only the gist and the summary I have discussed about these topics. So I'll not waste too much of your time, and you will get the brief and the basic gist of these topics. At the end, I am Dr. Naveen Agrawal, and thank you all for a very patient listening of this topic. The people who are new to my channel, I would request them to subscribe to my channel, as this gives us a lot of inspiration and motivation to continue the channel in the future. Thank you.